Hello everyone, this is Dr. Kim. Today I would like to talk about this case that I saw last week. So here what you're seeing is periapical radiograph of tooth number 6, 7, implant number 8. And what I'm most concerned about is the angulation or the location of implant number 8. Although I do not know how long ago this implant was placed, it does appear to me that this has been there enough for the normal osseointegration has occurred. And I want to draw your attention to the proximity of this implant to tooth number 7, which is the maxillary right lateral incisor. It's clear to all of us that in this interradicular distance, this implant has been placed more distally toward number 7, such that the distance that I can measure here, although my ruler currently is not calibrated for this radiograph, I would presume that it's anywhere around maybe a millimeter, maybe slightly more, but it's very close. That I think we can all agree. So my thought is, why was it placed this way? Could this have been placed more centrally in this edentulous ridge? And I don't know the answer. Unfortunately, we do not have a 3D imaging of this area. If we have a cone-beam CT, we would be able to better evaluate location of this implant in relationship to what's the word I'm looking for? Nasopalatin canal, or the duct that's located between the two central incisors. So besides that, I want to mention one more thing. Here we have a radio-opaque zone at the bottom of this radiograph. So this is a classic representation of a cone cut, and I want to briefly discuss how or why a cone cut image is generated. So in this example, the clinic was using a round cone. That again tells you that this radiograph was not captured at our school. We use rectangular collimator. So this was taken from outside, and this patient was referred to school for some other treatment. That's my understanding. So if you look at the border of this cone cut, we see that it's rounded rather than a straight line. That's how I know this clinic used a round collimator. And the fact that this area is radio-opaque, which translates to the fact that this part of the sensor did not receive any photon or any X-ray radiation. Then we can sort of visualize the overall shape and location of the cone, which is drifted more toward the apical region of the tooth. So it's been pushed more superiorly. However, I would say that this is still a clinically acceptable radiograph for what we are wanting to see. But keep in mind that you could have a cone cut image where you have loss of significant anatomic structure, such as the crowns of a tooth, or a crown of a tooth, or the apices, right, root apices. So for those cases you then need to retake the radiograph. So I wanted to briefly mention that. So if you want to get rid of this cone cut image, or if you want to fix this area, what you'd have to do is bring a cone, a round collimator, more toward this portion of the sensor so that you are giving radiation dose to this area. So now, having said that, I want you to see different projection of this area. So again, we have implant number 8. Here's tooth number 9. And from this particular view, the distance between the tooth number 7 and implant 8 looks even closer, maybe a millimeter, but perhaps not even a millimeter at this point. And that is due to slop rules or slop technique. right? So if you're not, if you have never heard of it, it's SLOB, which stands for same lingual opposite buccal. We just shifted the tube toward tooth number 9, which means if this implant were to be more lingually positioned, it will follow in the direction of the tube, but since this moved in the opposite direction, such that the implant appears to be moving more distally toward number 7, that indicates that this implant is relatively like buccally positioned within the alveolar process. Anyway, or that's yeah, besides the point, going back to our original topic, the fact that this is positioned more distally, you know, perhaps the dentist did obtain a CBCT imaging prior to the placement of the implant. I think what is important to recognize is that there's a nasopalatin canal in this region, and in my best attempt to estimate the location of the foramen, I want to say this is the approximate location of the nasopalatin foramen, and you see a trace of radiolucent channel that extends superiorly, and so I would presume this is the nasopalatin canal. So knowing that, maybe the dentist made an effort to place this more distally such that they would he or she would avoid the nasopalatin duct. But again, I really don't know the exact spatial relationship, because it is possible that you'd still be able to place an implant more centrally within the ridge if that implant is, you know, either buccally positioned relative to the nasopalatin canal. So that's still possible. But I think this is an just interesting topic to discuss, and again, emphasis on the importance of getting cone beam CT image in order to evaluate surrounding structures, anatomic structures, in this case obviously the adjacent teeth, but also the nasopalatin canal. Additionally, we would also have to consider the buccal concavity that's present typically in the maxillary anterior maxilla. So I hope you learned something new and how I go about evaluating implant placement, as well as the just two-dimensional images. Yeah, that's what I wanted to discuss. Hope it was again helpful. If you liked the video, please hit the like button if you haven't done so, and please click to subscribe, and we'll see you next time. Thank you.